Hi there, it is time for another presentation in the Healthcare of the Client 3 course. In today's session, I will talk about high-risk pregnancy, specifically pre-existing conditions. We will talk about various conditions which needs close monitoring because they contribute to pregnancy complications. Before we proceed, please make sure that you familiarize yourself with the outcomes for this module, which is found in the course overview in D2L. For some women, pregnancy presents significant risk because of the presence of chronic illness. Chronic illness are usually referred to as pre-existing conditions or pre-gestational conditions in pregnancy terms. And these are disorders that the mother had before conception or before the pregnancy, thus creating unique maternal and fetal needs in addition to the usual pregnancy-related feelings, needs, and concerns that the pregnant woman may have. Chronic illness stems from metabolic disorders such as diabetes, thyroid disorders, cardiovascular disorders such as hypertension, and heart valve disease. There can also be respiratory disorders including asthma and cystic fibrosis. The mother may also have some chronic gastrointestinal problems such as GERD or acid reflux, integumentary problems such as acne, which can be made worse by the pregnancy. We talked about this when we did the normal pregnancy and physiological adaptation, that some women will have acne and angiomas. There can also be some existing CNS disorders such as seizures and epilepsy, and the medications used to manage seizure and epilepsy can adversely affect the development of the fetus. Autoimmune disorders can also be pre-existing, such as systemic lupus erythematosus and myasthenia gravis. And also, the mother may be engaged in the use of illegal substances, such as marijuana, which is now legal in some states, and the use of crack cocaine or methamphetamines. Other illnesses may develop during pregnancy, which are known as gestational conditions. The bolded conditions are examples of conditions that develop as a result of pregnancy. Note that hypertension and diabetes and seizures can be pre-gestational as well as chronic conditions, and they can also be gestational conditions. When a chronic illness is made worse during pregnancy, we say that there is superimposition. So if a patient has hypertension and that hypertension becomes worse during pregnancy, we say that she has superimposed preeclampsia. Now let's look closely at some of these conditions, and we are going to start with diabetes. Diabetes is the most common endocrine disorder associated with pregnancy. As I said in the physiological adaptation, the production of insulin increases during the first trimester to try and accommodate for the excess glucose that the mother needs for fetal development. And this tapers down. And although diabetes puts pregnancies at a high risk, it can be successfully managed because after the first trimester, the insulin production starts to increase again, and also the body adjusts itself to where the insulin production and its demand is met. But if this is not met, especially if there is an existing condition such as the diabetes was pre-existing, then the control has to be done very well to make sure that there is not episodes of swings between hypo and hyperglycemia. Diabetes can be successfully managed with a multidisciplinary approach and strict maternal glucose control. While chronic diabetes is present at the time of conception, gestational diabetes is diagnosed at about 24 weeks of gestation. So what is diabetes? You have studied this when you did glucose regulation in Health Curve the Client 1. But just to give you a recap, diabetes is a group of metabolic disease characterized by hyperglycemia resulting from either a defect in insulin secretion, a defect in insulin action, or both of these two. Hyperglycemia causes hyperosmolarity of the blood, which attracts intracellular fluid into the vascular system, resulting in cellular dehydration and expanded blood volume. The signs and symptoms include polyuria and glucoseuria, because you find glucose in the urea as the kidneys attempt to regulate excess vascular volume and excrete the unusable glucose. Polyuria along with cellular dehydration causes excessive thirst, which is known as polydipsia, so they will be drinking frequently. Also, ketones and acetones are screened in the urine because the body burns more protein in a person who has diabetes by burning their muscle and fat. Excess ketones causes diabetic ketoacidosis, which is marked by a sweet fruity breath. So you will smell a fruity breath if the person is going into ketoacidosis. There is also sometimes weight loss which occurs as a result of the breakdown of the fat and muscle tissue, but obesity should be noted as a risk factor for diabetes. And this tissue breakdown causes a state of starvation that compels the individual to eat excess amount of food, and this is known as polyphagia. So these are the signs and symptoms that you are going to see with diabetes. Now let's classify diabetes as it relates to pregnancy. We have already said that diabetes can be chronic, which is pre-gestational, or it can be diagnosed after 24 weeks, which will be gestational diabetes. There are 4 main classifications of diabetes. We have diabetes type 1, and that is the insulin dependent diabetes. And we have diabetes type 2, which is the non-insulin dependent diabetes. And also you can have gestational diabetes mellitus, and it's any degree of glucose intolerance with onset or recognition during pregnancy, and other specific types that is either caused by infection or is drug induced. For example, let me ask you a question here. What are some examples of medications that increase blood glucose levels? If you answer steroids, then you are correct. Good job. Steroids, glucocorticoids, and corticosteroids increase blood glucose temporarily when the patient is taking these medications, and this can cause transient hyperglycemia or diabetes that will need management with insulin or other medications. So let's talk about gestational diabetes. Gestational diabetes results from the physiological processes that occur with pregnancy. Remember that adjustments in maternal metabolism allow for adequate nutrition for both the mother and the developing fetus. And during the first trimester, the pancreas increases insulin production to manage the excess glucose levels as a result of the pregnancy. Insulin production tapers down in the second trimester, leveling out in the third trimester. There is also a decreased tolerance to glucose and increased insulin resistance, which is as a result of decreased hepatic glycogen stores, and increased hepatic production of glucose occur. This progresses to the development of diabetes, and gestational diabetes is mainly insulin dependent, which means that insulin can be used to manage this type of diabetes. Pregestational and gestational diabetes can cause other complications such as vascular disease and retinopathy or neuropathy, and so it is very important that we manage these aggressively to prevent the complications of neuropathy and ulcers that can be as a result of that. In managing diabetes with the patient, there has to be preconception counseling, and this includes discussion of maternal and fetal risks associated with the pregnancy. Maternal risks and complications of diabetes include risks to the mother, such as the perinatal mortality rate, which is 3 times high or higher for women with diabetes than for women who do not have this disease. So risks are associated with one of the following complications: macrosomia, which is a large fetus, which increases the risk of labor complications such as dystocia and predisposes the woman to cesarean birth. Then you also have a complication called hydromnios, and we talked about polyhydramnios sometime. And this is an increase in the amniotic fluid, and this can cause placenta abruption, which is a bleeding disorder, a late pregnancy bleeding disorder, which can be very serious because it can cause hypotension and other distress to the fetus. There is also the resulting uterine dysfunction that can occur as a result of hydromnios and postpartum hemorrhage and infections. There is also the likelihood of UTIs with diabetes and other infections which are common and severe for pregnant women with diabetes. In addition to the mother, in addition to these, the mother may also suffer from preeclampsia or be at a higher risk for preeclampsia, and ketoacidosis can send the mother into a diabetic coma or ketoacidosis coma, and hyperglycemia and hypoglycemia, which will be swings from one extreme to the other. And so these are all complications that can be present if diabetes is either diagnosed as pregestational or gestational. The fetus may also be at risk if the mother has diabetes, and the fetal or neonatal risks include sudden and unexplained stillbirth and congenital malformations, as well as cardiovascular system, central nervous system, and skeletal system problems. It also increases the risk for infection in the fetus as well, as there can be amnionitis. Now let's look at the care management for diabetes. During the history taking, the nurse should ask the client about existing diagnosis of diabetes or prior history of gestational diabetes with the assessment or history, and then complete glucose screening at 24 to 28 weeks for all pregnancies. The nurse should also complete a urinalysis to identify glucosuria and ketonuria. UTI and also creatinine is obtained. Creatinine levels are obtained to assess for baseline kidney function, since diabetes can affect perfusion to the kidney tissues. Preliminary results, which is positive for hyperglycemia or any of the mentioned tests, is followed up with further assessment or further testing. So there are 2 forms of testing that can be done. We have the one-time glucose tolerance test, and we have the 2-level glucose tolerance test, and each of them will have different instructions for the mother. Antepartum care for the client with pre-existing or gestational diabetes should focus on encouraging proper ADA diet by spreading out their carbohydrates and having small consistent meals instead of having large meals. The average diet includes 2,200 calories for the first trimester, up to 2,500 calories in the second and third trimester per day. Exercise should be stressed because walking daily or at least 30 to 60 minutes per day and monitoring blood glucose levels closely will help reduce the complications of diabetes. Self-monitoring of glucose and recordings should be reviewed at every prenatal visit to determine if the diabetes is being well managed or not. And then the nurse will also obtain hemoglobin A1C to determine severity of the diabetes. Note that iron deficiency anemia can falsely increase the hemoglobin A1C results, and so you have to obtain the CBC and also to see if there is enough iron in the body. Adherence to insulin therapy by taking the right amount and taking it at the right times will also help with the effective management of the diabetes. So educate the client about the signs and symptoms of hypo and hyperglycemia. Hyperglycemia can result from hypoglycemia, can result from excess insulin, insufficient food intake, and excessive exercise or workouts. Indigestion, diarrhea, vomiting, which is associated with the first trimester of pregnancy, and or rapid insulin or regular insulin use. So gradually modified insulin can be used with other hypoglycemic agent to be able to avoid hypoglycemia, and also educate the client not to have an empty stomach for a very long time. Other interventions include checking blood glucose level when symptoms first appear for the hypoglycemia, and if the blood glucose is less than 70 milligrams per deciliter, you will ask the client to eat 2 to 4 glucose tablets or gels, or eat about 8 to 16 grams of carbohydrate immediately in the antepartum care, and then recheck the blood glucose level in 15 minutes. If glucose level is still less than 70 milligrams per deciliter, then you can ask the client to eat 2 to 4 additional glucose tablets, and then recheck the blood glucose level in 15 minutes. And if it's still low, then you notify the provider. You should know the normal levels of glucose in an adult. On the other hand, hyperglycemia or DKA may result from insufficient insulin. So if they are not compliant with their insulin regimen, overeating, infection and illness, or emotional stress and insufficient exercise. And this should prompt the nurse to perform a glucose check to see if the blood sugar levels are high. Fetal surveillance is also forms part of the antepartum care for management for diabetes. So the goal of fetal surveillance are to detect fetal compromises as early as possible and prevent intrauterine fetal distress or unnecessary preterm birth. The provider may use fetal assessments to determine the mode of birth, whether vaginal or cesarean, and also if the fetus needs to be delivered at 40 weeks before they become too large for vaginal birth. Ultrasound is used as often as every 3 to 4 weeks to monitor fetal growth and estimate the fetal rate and detect hydramnios or microsomia and congenital anomalies such as neural tube defects that can be detected around 20 weeks. Maternal serum alpha phenylprotein is also obtained and performed between 15 to 20 weeks of gestation, ideally between 16 and 18 weeks of gestation, to determine if there are any defects as a result of diabetes. And if the ultrasound identifies that there are any problems, the mother can undergo an electronic fetal monitoring with non-stress test to determine the heart rate pattern, which we will talk about in the subsequent presentations. Okay. There are various patient education that is related to self-care and glucose monitoring for diabetes. So, as I said, exercise, diet, and eating a well-balanced diet, including daily food requirements for a normal pregnancy, such as increasing folic acid and decreasing the amount of carbs, and making sure that they follow the 2200 or 2500 diet that is appropriate for their term or the gestation of the fetus. Divide the daily food intake among 3 meals and add 2 or 3 snacks depending on individual needs, and avoid eating large meals, as I said earlier on. And also eat a substantial bedtime snack to prevent a severe drop in blood glucose level during the night if needed. Take daily vitamins and iron as prescribed to prevent low iron, which may affect the hemoglobin A1C results that the healthcare provider may obtain. And avoid foods that are high in refined sugar. Eat consistently each day, and you also have to ask the client to eat foods that are high in dietary fiber, and avoid alcohol and nicotine, and also limit caffeine. So if the client is trying to reduce the amount of refined sugar, you also have to let them know that they should avoid excessive use of non-nutritive sweeteners, because excessive use can also contribute to other problems. If the patient is in the intrapartum period, then during the intrapartum period, the nurse should assess and monitor the client for signs of dehydration, hyper and hypoglycemia. If hypoglycemia occurs, the nurse will notice signs and symptoms including irritability, hunger, sweating, nervousness, personality changes, such as change in level of consciousness, which is marked by confusion, weakness, fatigue, blurred or double vision, dizziness, headache, pallor, clammy skin, and shallow respirations with a rapid pause. And lab values will identify blood glucose levels less than 70 milligrams per deciliter, and also urine samples may be negative for sugar and acetone. Interventions include administration of a piggybacked pump-controlled infusion of a solution containing 5% dextrose for glucose levels less than 70 milligrams per deciliter. This is because in the intrapartum period, the patient may be NPO if there is the need for cesarean birth, and so patients are mostly kept NPO during the birthing process. If the woman becomes unconscious, then the nurse should administer 50% dextrose IV push, and or 5 to 10% dextrose in water IV drip, or 1 milligram of glucagon intramuscularly to cause the glycogen stores to be transformed into glucose, which will be needed by the body, and obtain a blood and urine specimen for lab testing. After this is done, then the nurse should proceed to obtain hourly blood glucose levels and adjust fluid and insulin regimen to maintain blood glucose levels between 90 and 110 milligrams per deciliter. The nurse should also assess and educate the client about hyperglycemia or DKA in the intrapartum period. So we have finished talking about hypoglycemia. We are now talking about hyperglycemia. And the signs and symptoms the nurse will see with hyperglycemia include thirst, nausea or vomiting, abdominal pain, constipation, drowsiness, dim vision or blurred vision, polyuria, and there will also be headache with flushed or dry skin, and also rapid fruity breathing. And so the smell of the breath is going to be fruity smelling, and the patient may also have weak and rapid pulses. Lab values are going to test positive for glucose in the urine and also acetone, and the blood glucose levels by AccuCheck is going to be greater than 200 milligrams per deciliter. So once this is established that the patient is in hyperglycemia, then the nurse should proceed to perform these interventions by notifying the primary healthcare provider, administer insulin in accordance with blood glucose levels, and give IV fluids such as normal saline, or even have normal saline solution to dilute the blood concentration of glucose. Also give potassium when urinary output is adequate, because insulin infusion drives potassium into the cells and may cause hypokalemia. So you want to give supplemental potassium if we are using an insulin drip to manage the hyperkalemia. And we can also administer bicarbonate if ketoacidosis occurs and the pH is less than 7, because as we know, DKA is a metabolic acidotic state. While managing the hypo and hyperglycemia, we shouldn't forget that the mother is not our only client or patient, because we have to also make sure that the fetus is doing well in the intrauterine environment. And so we are going to monitor for contractions and possible signs of labor. And we're going to perform continuous fetal heart monitoring to see the fetal heart patterns, to make sure they are reassuring or normal. And then inform the rapid response team and neonatologist or the pediatrician to be present during the birthing process, because the fetus may need resuscitation. Postpartum care for the clients with diabetes include insulin requirements, and the insulin requirement normally is going to decrease substantially after birth. Most of the time, gestational diabetes will resolve after the pregnancy, but some women proceed to have chronic diabetes after birth has occurred. And so you have to educate the woman that they might still need insulin therapy and other other glycemic control measures after birth. If the mother has pregestational diabetes, which becomes chronic diabetes, or if they had gestational diabetes which becomes chronic diabetes, or they had pregestational diabetes, then we should ask them to be careful with the use of oral contraceptive due to the risk of thromboembolism, because as we know, diabetes also affect the tiny blood vessels, and if you are taking oral contraceptives, that can increase the chances of getting a thromboembolism or DVTs. All right, let's move on to thyroid disorders. Thyroid disorders are pre-gestational conditions that occurs in approximately 2 to 17 in 1,000 pregnancies. Clinical manifestations of hyperthyroidism include heat intolerance, diaphoresis, fatigue, anxiety, emotional lability, which is swinging moods, and tachycardia. There is also some weight loss that can be associated with hyperthyroidism. Diagnosing hyperthyroidism is difficult because many of these symptoms that I have mentioned are associated with normal pregnancy, and signs that may help differentiate hyperthyroidism from normal pregnancy changes include the weight loss. As we learned, in pregnancy, the client is supposed to be gaining weight at each gestational week, and so if they are losing weight, then this can be a classic sign that there is something wrong. So goiter can also develop, which is the enlargement of the thyroid gland in the neck, and this is going to be seen as a huge lump in the base of the neck. And so once that develops, then we know that there is hyperthyroidism going on, and also a pulse rate that is greater than 100 beats per minute. Lab findings typically include elevated free thyroxine, which is T4, and also triiodothyronine T3 levels, and these are greatly suppressed by the thyroid stimulating hormone, which is the TSH levels. So hyperthyroidism increases the risk for developing severe preeclampsia, which is hypertension induced by pregnancy, and heart failure during pregnancy. Treatment of hyperthyroidism are mainly based on drug therapy, consisting of the use of PTU in the first trimester, or the use of methimazole, which is also known as MMI, in the second trimester. Both drugs are effective at controlling symptoms, but both have potentially dangerous maternal and fetal side effects. PTU can cause hepatotoxicity in the mother and is serious enough to require liver transplantation. When taken during the first trimester of pregnancy, MMI or methimazole can cause some esophageal atresia and facial anomalies, hearing loss, developmental delay, and congenital cardiac malformations in the fetus. So we should be aware of that. Some nursing considerations that nurses have to be aware of is to monitor for thyroid storm, which is a complication of hyperthyroidism. This is an emergency situation, and a woman with this emergency disorder may have fever, restlessness, tachycardia, vomiting, or stupor, and the nurse should intervene by using IV fluids and oxygen, which is administered along with high doses of PTU. After administration of PTU, iodide is given, and other medications include antipyretics to prevent fever, and also dexamethasone and beta blockers for controlling the heart rate and blood pressure. On the other hand, hypothyroidism can also be a pre-existing condition, and hypothyroidism occurs in 2 to 3 pregnancies per 1,000 pregnancies. Because severe hypothyroidism is often associated with infertility and an increased risk for miscarriage, hypothyroidism should be managed very closely also. Treatment include the use of levothyroxine or Synthroid, which is most often prescribed during the pregnancy. When a patient has hypothyroidism, the nurse should be aware of these considerations. Iron decreases iron decreases the absorption of the T4, and so you have to teach the client to take levothyroxine at a different time if they also have anemia and they have been put on an iron tablet or ferrous sulfate tablet. So you want to educate them to leave at least 4 hours in between these two medications to make sure that the Synthroid is being absorbed and is being effective. Other metabolic disorders include maternal phenylketonuria, and this is recognized this is a recognized cause of